événement. En tout cas, vraiment, nous les remercions infiniment, parce que quand je les entends me dire qu'ils ont fait 30 heures de vol ou 25 heures de vol, c'est vrai qu'il fallait le faire quand même. Ils ont vraiment voulu venir à Paris et je crois qu'ils ne sont pas déçus. Voilà, Beryl va animer cette table ronde avec Leonardo Orlando. Et Beryl, je te laisse.
So we'll have the chance to listen to eminent clinicians and researchers on the question of trans-identification in adolescence, and of course the concept of rapid onset gender dysphoria. So I really would like to thank them all for flying from so far. We also had a chance to meet most of them last year in Finland, and it's been it's really it's so great to be able to listen to them and to all the information that they have to share. So we are going to change a little bit the program. Xenia and Roberto asked for that because there are important news concerning the W path that they want to share. But first of all, we would like to listen to Lisa LIttman. I'm looking at your background, but you're a medical researcher from the Institute for Comprehensive Gender Dysphoria Research in the US. And we'd like to listen to you on how did the hypothesis of rapid onset gender dysphoria emerge and why has it been so controversial and so politically wrapped? Thank you, Lisa.
Is this on? Okay. All right, so before I describe how the ROGD, rapid onset gender dysphoria hypothesis emerged, I would like to state what the ROGD hypothesis is. So the ROGD hypothesis proposes that social influences, maladaptive coping mechanisms, and other psychosocial factors can contribute to the development of gender dysphoria and transgender identification in recent populations of teens and young adults with late onset gender dysphoria. The ROGD hypothesis was developed as a potential explanation for the recent striking changes in the patient profile of individuals seeking care for gender dysphoria, and it is meant as an explanation for some, but not all, cases of late onset gender dysphoria occurring in teens and young adults. There have been tremendous changes in the patient profile for gender dysphoric patients. For decades and decades and decades, there have been two types of gender dysphoria: late onset gender dysphoria, which occurs during or after puberty, but has typically involved adult males, and early onset gender dysphoria, where the symptoms begin during childhood. And this has affected males and females, but with a predominance of males. And that was what the gender dysphoria landscape looked like for decades. However, starting in the mid-2000s and then rapidly accelerating in the 2010s, there was a monumental increase in the number of adolescents with gender dysphoria, and an even greater increase in teen females with gender dysphoria. So much so that the sex ratio reversed. Where it was previously predominantly male, it became predominantly female. Also, a new presentation of gender dysphoria emerged, where late onset gender dysphoria was in the scientific literature for males only. Now there was a new presentation of late onset gender dysphoria in females. And this new population had a higher rate of psychiatric and neurodevelopmental conditions, which often occurred before the onset of gender dysphoria. The responsible question to ask is, why did these changes occur? And we don't have a definitive answer, but some have hypothesized that these changes are due to decreased stigma around trans identification, increased availability of information, and increased access to transition services. And although these explanations could explain why there is a tremendous increase in the numbers, it doesn't explain why is this increase predominantly in teenagers, why is the sex ratio reversed, and why is there a new presentation of gender dysphoria, late onset in females. And so the ROGD hypothesis was created as a possible explanation for the not yet explained changes in the population of people with gender dysphoria. And with these monumental increases and changes, it's likely that there are multiple factors contributing. There were some additional clues about what could be happening, because around the time that gender clinics started reporting these population and clinical changes in patients, parents were reporting situations where their children became trans-identified, first trans-identified as teenagers, in clusters of cases. Specifically, they described groups of teenagers from the same friend group, and sometimes the entire friendship group, going from not trans-identified to trans-identified around the same time. Also, there was extensive social media content that encouraged young people to believe that vague symptoms were signs of being transgender, that transitioning as soon as possible was the only way that they could ever feel better, and that encouraged them to mock individuals who were not trans-identified. So why should we consider psychosocial factors? It would be surprising not to in this setting. But because the shift in patients seeking care for gender dysphoria has been driven by this enormous surge in teenagers, it makes sense to look at factors that are especially salient to adolescence as a developmental life stage, such as social influences and peer contagion. The pattern of clusters, although not definitive, suggests a need to explore social contagion. And because the social media content contains similarities to content associated with the spread of eating disorders, the role of social media in gender dysphoria and trans identification deserves exploration. And because clinicians have documented these high rates of psychological conditions, often predating the gender dysphoria, looking into other psychosocial factors is also important. So what is the state of the ROGD hypothesis? As we've heard, there has been a tremendous pushback, which other people on this panel will describe. But the evidence to support the ROGD hypothesis is early but growing. One main criticism of the ROGD hypothesis is that the initial study was based on parent report. However, there have been additional research studies and other that include asking individuals firsthand about their own experiences and other relevant evidence appearing that have strengthened the case for the ROGD hypothesis. Thus far, 4 studies have found evidence to support the ROGD hypothesis, and to date, the following aspects of the hypothesis have been supported by the accounts of detransitioners and desisters as being relevant to their experiences of gender dysphoria and transgender identification. So social influences, including their friend group behaviors, peer pressure, social media, social learning, maladaptive coping mechanisms, misinterpreting the symptoms of a mental health condition or trauma as gender dysphoria, and as was mentioned before lunch, difficulty accepting oneself as gay, lesbian, or bisexual.
Thank you, Lisa. This one? Okay. Thank you very much, Lisa. I think that we are all very grateful here to have you made all this way from the US. Now we're going